What I want to do is focus on actually the bigger part than what they talked about. And that is that even though many of you are persons with Parkinson's or persons with something, the reality is you're still mostly a person and not a person with Parkinson's. And I think that sometimes in the medical system gets lost, where people get identified as being their disease. The reason why that's important is twofold. One is just because it's the right thing to do, to remember that this person is a person and not a Parkinson's person or Parkinson's disease. The Parkinson's over in room 338. But the other reason is because it actually is based, and I'm going to talk about evidence-based medicine, in the evidence, which says that really, if you look at any chronic condition, Parkinson's, even Alzheimer's, but especially things like Parkinson's and heart failure and pulmonary problems like emphysema, that the biggest component in terms of outcomes is what you do, not what the doctor does. And I know that's hard to hear sometimes, because it means I have to take some responsibility for my disease, but I don't like to think about it as responsibility because it sounds pretty negative. I like to think about it in terms of controlling your destiny. And the fact is you have a significant portion of control over the outcomes of any condition that you have. This is not just applicable to Parkinson's. But actually in Parkinson's we have a fair amount of evidence that it plays a really significant role. We were kind of joking before. Yesterday I was giving a talk on Alzheimer's at Westminster Oaks, and people were saying, what's better, to have Alzheimer's or Parkinson's? The reality is, if I had to choose, I'd choose Parkinson's, because there is more chance to control it and more chance that you have a greater chance in not being just dependent on having really good doctors and really good health systems. So I want to talk about something that we call person-centered care, which should have been there from the beginning, and I think to some degree in most doctors' hearts has always been there, but it's now getting the proper attention it should have. I want to talk about this concept of quality of life, and it's a little bit different than what Dr. Schmidt said in terms of what we measure in research called health-related quality of life. And then talk about mom's advice, because it turns out that mom's advice probably is one of the most important things we should listen to. And finally, about controlling your destiny. So what is person-centered care? There's a group called the Institute of Medicine, which is a collection of specialists in all aspects of medicine who every year meet and look at problems in American care. They were the ones who came out with the report about medical errors, that we have some 50 to 100,000 people a year die due to medical errors. So it's a lot bigger than the 6,000 who die due to poor Parkinson's care. And part of the reason why I bring this up is because the solution is not only to get our system to do a better job, mark that left leg as don't cut this leg off, and mark the right leg, cut this one off when an amputation is happening. That simple makes a big difference in the system, but it's also what you can play in the role. So the IOM says it's care that's respectful of and responsive to individual patient preferences, needs, and values. Now I want to point out the individual values part, because this is a part that gets lost in evidence-based medicine sometimes. Because what the person thinks and what they feel and how they react is a very important part of the medical decision making. Another group called the Agency for Health Research and Quality says patients become active participants in their own care and receive services designed to focus, again, there's that word, on their individual needs and preferences, in addition to advice and counsel from health professionals. The reason why this is so important is because, and especially for you with regards to Parkinson's is primarily a condition that affects older people. And the older you get, the more different you get from another older person. If you look at, if we had all of 2-year-olds, like Dr. Malati's little girl here, they would all be very different in the way they behave. But if we were to measure physiologically those little girls, they would all be pretty close to the same. They would all have about the same potassium level, about the same muscle speed, about the same reflexes. They would be pretty similar. But as you get older, you start accumulating differences. Some of that is just chance, mutations that occur because of gamma rays hitting you, or diseases that you incur, or accidents that you have, or your psychological responses to things, or whether you listen to rock and roll. All of these differences gradually accumulate, and 80 years or 70 years is a long time to accumulate differences. And so this is where we have to blend a evidence-based practice that says these are the right things to do with the person and whether it fits their individual values and needs. Now, I can help with telling you what the recommendations are. And I use apps all the time for this. I carry my iPad into the room when I see a patient, and I'm constantly looking things up to make sure I'm up to date on the right thing. That's the evidence-based side. But only you can say what is right for you. And you need to get the information to be able to make that decision. So evidence-based medicine is what's the best research. That's very important. Good studies that have looked at people who look like you and said, here's what works, here's what doesn't work. We don't have enough of that in many cases. But when we do, that definitely should be looked at. But also clinical expertise. This is where the idea comes in that experienced neurologists and experienced geriatricians and others who know what to do about this particular problem are likely to do better than someone who doesn't have that experience. But the third one, and of equal value, is patient values. You have to value the intervention for it to work. We can't be the ones who say, this is it, take this, and you'll be fine. So many times, I'm sure you've heard in your own lives that just doesn't work out that way. Understanding your values is critical to the patient outcomes. So Don Berwick, who was formerly the head of the Centers for Medicare and Medicaid Services and started the Institute for Healthcare Improvement, calls himself an extremist in patient-centered care. He says where we need to get in patient care is that patients get exactly what they want and need, exactly when they want and need it. Now, I know I don't get that with my own care, and you probably don't either, but that should be what we aspire to get. The other thing he says is instead of hosting patients in our system when they come to our hospital, we ought to see that we are actually being guests of their system. The patient is the center of the care. Every medical decision really ought to be on informed consent. And a lot of people don't understand what informed consent is. In fact, a study of doctors way back in 1974, surgeons asking them what they thought informed consent was, they said making sure the patient signs the form before you do the surgery. So think about what informed consent is, because I'm going to get into that. And then the last one is a saying I like from Maria Huxley. No one knows best, for we all know differently. So the doctor knows a lot. Hopefully you'll have a doctor who knows a lot about your problem. But ultimately, you have to be the one to make the decision since you're liable to be different than the doctor. In fact, I get to lecture to the first year students every year, and I've actually done this at USC and then Oregon Health Sciences and now FSU, where I've moved 3 different med schools. And I walk in the first day and I say, well, there's a big group of people, usually in an amphitheater. Say, well, you look about as abnormal as any other group of medical students I've ever seen. You know, these are all the straight A students, and they kind of go like that. I say, well, think about it. You've made a decision now to start 4 years of medical school, 3 years of residency, maybe 2 or 3 more years of fellowship or extended residency, and to spend your life dealing with sick people every single day. Maybe having the license to stick a knife in them. Maybe putting tubes into different orifices, maybe dealing with urine and feces and vomit and blood. You think that's normal? The normal person in the room is the patient. You're the abnormal one. Keep the patient's view in front of your mind. So what's informed consent? Informed consent is that you pay a doctor to go to get a recommendation. So you want to hear what that doctor recommends. And ideally, they'll also tell you what the risk is of that recommendation and what the likely benefit is. But you also need to hear what the alternatives are and what the risk and benefits of those. And then, like your study about nothing doing better than the medicines on antidepressants, what's going to happen if I don't do anything? There's a lot of times when not doing something is actually a perfectly reasonable choice. And you need to know the risk and benefits and decide what to monitor. Because you may decide, I'm going to go on and wait on this. I'll give you an example. Because of this overemphasis on health screening right now, a lot of people are getting screened for things that there isn't very good medical evidence. Like a lot of people get CAT scans of the body for different reasons, and they look at their thyroid, but they're not actually screening the thyroid. And they find these things that look like cancer. And so the rate of thyroid surgery and detection of cancer has gone up dramatically, but the death rate for thyroid cancer has not gone down at all. In fact, it's actually gone up. Why? Because the person really didn't need that surgery in the first place. It wasn't the kind of cancer that was going to be bad for them. Why? Because 10% of thyroid cancers go away on their own. So in certain cases, and this is why you need informed consent, you need all the information you need to make a good decision. Sometimes the best thing to do is to wait and let's just see what's going to happen. And that's where having a good doctor you can go back to and get checked on again and follow this closely is often the best choice. So I want to talk about quality of life. Quality of life is inherently subjective. And guess what? Could I have a glass? Or that tea right there is mine. When doctors, studies that have looked at how well do doctors, nurses, and social workers, the kind of big three, how well are they at accurately determining what the patient thinks of their own quality of life? Guess what? Get out a coin. 50-50. And surprisingly, I always think social workers are the best at this kind of stuff. No better than doctors. 50-50 chance of estimating that person's view of their quality of life. So quality of life, the evidence is you have to ask the patient what they think of their quality of life. And it's not strongly related to objective disease. Some people can be at stage 5 in Parkinson's and say their quality of life is good. And other people can be at stage 1 or 2 and say, this is horrible. So this is a very important point for you to know. Quality of life is a modifiable concept. So if you take yourself and you were to rate yourself on this scale, -3 terrible quality of life, +3 great, and then the different gradations. Can you all see it in the back there? So -3 is terrible, -2 is very bad, -1 is bad, 0 is neutral, 1 is good, 2 is very good, thank you, and 3 is great. Then you can say, all right, what could I do to enhance my quality of life? Now sure, good medication treatment might do that, but not necessarily. So the essence of quality of life is daily experience. And it's a very simple equation. Basically, people who rate, and this is all from research on quality of life, people who rate their quality of life as high tend to have, on the balance, more positive experiences than they have negative experiences. And you can think of 3 main realms of positive and 3 main realms of negative experiences. So in positive, things like pleasure, all kinds of activities that might give you pleasure. It doesn't have to be that kind of overwhelming type of pleasure, but just hearing good music, having a beautiful viewpoint, seeing a beautiful scene, for instance. Anything that gives you some pleasure is usually counted. If you ask, well, what was that like? What did you feel? What did you think about? How did your body feel? They'll tell you that it was a positive kind of experience. Anything that leads to successes, completion of a project, getting some recognition or accolades, anything where you feel that feeling of success. And then senses of purpose. A person who says, yes, I go to those to those choir meetings because I really feel like it helps other people to see me there, or I volunteer, or I help teach, or I do this kind of outreach to people who need it. Any sense of purpose that a person has gives you positive experiences. On the other hand, and this is obviously true in Parkinson's, there's a lot of reasons why we might have negative experiences. Physical experiences like pain or difficulty moving or falling or fear of falling all fit into that kind of physical part. Actually, fear of falling probably fits better into psychological side, but feelings of depression or helplessness or any of those kinds of feelings would be psychological. And then the very big issue of interpersonal. And I know a lot of people tell me after they're diagnosed with Parkinson's that their friends drift away. They may not want to be around them again. And it is true that unfortunately studies have shown that older people, because illnesses are common, tend to be kind of negative about another person's illness. I know a lot of times in long-term care facilities, for instance, they'll say they don't want to have walkers in the dining area. Well, I think that's kind of stupid. I see any kind of assisted device as freeing. That's why I never say someone's wheelchair bound. They're not bound, they're liberated because they get to go somewhere now. So we need to think about the terms we use and the attitudes we have towards people, because a lot of times those interpersonal negative experiences are created by bad attitudes that people have about us. So this is from research in terms of, well, how do I move then from a lower quality of life to a higher quality of life? Start trying to have more positive experiences. You may not always be able to control all the negative experiences. With Parkinson's, there are some physical aspects, even with the best treatment, that you'll still have to cope with. But you still can control the positive experiences. This was a study that looked at what were the percentages of positive versus negative experiences that people who rated themselves in each one of those categories. So if a person was a 3 on high quality of life, 75% of their daily experiences were experienced as being positive, and only 25% were negative. If there were a -3 on the other hand, and notice the difference, 7% were positive and 93% negative. In other words, it's easier to get a high quality of life because you don't have to have as many positive experiences as all the negative experiences that contribute to bad quality of life. So it's been actually found that if you're able to increase your positive experiences by 25%, you'll move up one level in the scale. So you can take those positive experiences, whether they're success or whether it's in terms of a sense of purpose, and say, what am I not doing that I could increase my positive experiences right now that would increase my quality of life, even if I can't change the physical aspects of my Parkinson's? Maybe I'll stop right there. I have some other important things, but just see, because this is a new concept for a lot of people. Any questions about that, around the positive and negative experiences? Yeah, that's a very good point. So the question was, why on the chart isn't neutral 50-50? Probably because most people are kind of tolerant of negative experiences and learn to live with them. And so they're willing to accept, on the balance, a bit more negative experiences than positive experiences, and still say, remember, all these ratings come from a personal rating on the part of the subject, and this was all age groups up to 85, are willing to accept more negative things. They're coping with things, so they're still having negative experiences, but they see their quality of life as neutral. Okay, so how do you work to increase go up the scale? Increase your positive experiences. Try to find more pleasurable activities. There's a lot of times, we call it inertia, when it's hard to get going on things. And if you can make a decision today, I'm going to add this particular positive experience. It's actually a good idea to, if you're going to think about doing this, to keep a journal and write down the positive and negative experiences that just occur automatically without trying to do any change, and then kind of look at your daily accounting and then start thinking about the things that you've wanted to do and haven't done. On the other hand, you can try and decrease your negative experiences, and a lot of times physical may not be as modifiable in Parkinson's, but psychological often is. This is why I thought it was so interesting that seeing a counselor or seeing a social worker was much more likely to get rid of the negative experience of depression than taking a medication was. That's an interpersonal interaction with someone, just as Dr. Schmidt said to the answer to the question. The psychological aspects, trying to say, what good can come out of this situation? I was talking yesterday with a man who has Alzheimer's disease, who's, you might have heard of him, Sandy Halpern. He's very aggressive at trying to get people to change their attitude and stigmatizing thoughts around Alzheimer's. And one of the things he talks about that I thought was so interesting was, he's a dentist, he's very bright, he was taught at Harvard. Now he can't remember things that he just remembered just like that before. And what he said was, one thing I've tried to do is when I can't remember something, instead of going, I can't remember this, go, I guess it wasn't very important. Just changing what he tells himself, his self-talk about it, then makes it easier for him to remember it. And he finds that his memory actually gets better the less he rides himself about his memory. Okay, the next thing I'd like to talk about is that, unfortunately, for most people, and actually it isn't true for all, but for most people, Parkinson's is a progressive condition. It will get worse with time. And so this is one of those mental changes. We can say, oh my God, where am I going? Or we can say, all right, let me anticipate this and start to prepare for it. Now, this isn't such a bad thing. In fact, anybody, and many of you probably are in this situation, just looking at you, retired. Mm-hmm. Now, I'm not going to ask for a show of hands because it's kind of embarrassing, but do you know people who were forced to retire versus people who chose retirement? Because the evidence is people forced to retire have bad outcomes, and people who choose to retire have very good outcomes. Retirement is a change, and planning for retirement is anticipating that and taking all the relevant steps. I have a favorite saying, how do you know what you're committed to? By the results. If you got the result, you were committed to it. And how'd you get there? You took every step you needed to take to get there. A lot of people say, well, I'm at A, I want to be at point B, and somehow I end up at C. Oh no. Well, the reality is you took every step you needed to take to get to C. You can make decisions along the way of where you want to get. And that's where the anticipation comes in. So when you think about something like decreased mobility, the stages that Dr. Schmidt mentioned, well, what can we anticipate about that? It could be that we could start looking at our housing to say, is this good enough for me? Is this going to satisfy my needs? Do I need to be thinking about a physical therapy evaluation and maybe some assistive devices? It's even true for driving. We ought to really think, as soon as, what I would think would be ideal, but they'll never believe it because they're teenagers, is you say, okay, here's your driver's license. In a number of years, decades, you're going to have to think about not driving. It happens to every single person. It's a reality. So the problem is our whole system doesn't anticipate that. Because if you look at people who are homebound in Washington, D.C. versus Los Angeles, there are much fewer people in D.C. Why? Because they have the metro. They have a great alternative to driving. And what we need to really be thinking from a systems viewpoint is our system called the United States. And how are we going to develop systems that take care of this reality that every older person stops driving sometime? There's a few 100-year-olds and 90-year-olds who keep driving, but by and large, it's a normal aspect that we should be thinking about. And we ought to be taking some planning for alternative transportation methods. And once you do that, once you open your mind to thinking about it, all kinds of possibilities come up. There's an incredible story in Boston where they decided, well, this is a problem and it costs a lot for senior transportation. And so a group of elders started this program where they would volunteer and drive people to doctor's offices and shopping and things. And what they'd get for doing that was a voucher. And they would bank miles so that 5 years down the road when they couldn't drive, they had all this vouchers that then they would use to pay for the driving when they couldn't do it. And it was people taking care of themselves. And then the other one is anticipating how I'm going to replace new positive experiences with the new negative ones that I have. And that actually is, I see all the time. I teach often in OLI, the Osher Lifelong Learning Institute, and you see so many people there who say, I'm going to increase the times that I go and get more education, I spend more time with a support group, I come to the chorus, I do other kinds of new activities that replace some of the activities I used to be able to do and can't do anymore. So here's mom's advice. Eat good food. A Mediterranean diet is probably the best. Get enough sleep, drink water, all things in moderation, manage your stress, and exercise. And I wanted to focus a little bit on some of these. Don't have time. There's actually good evidence in all of these areas about the benefits in aging in general, and especially aging with a chronic condition like Parkinson's. So stress management, one of the things about stress management is it almost always results in positive experiences. So it contributes to quality of life. And there are many different techniques for stress management. One is called mindfulness. I think Dr. Malati mentioned mindfulness when you were talking about one of the classes. About Tai Chi. Yeah, so mindfulness is a particular way of thinking about things, and there are classes in most cities where you can take trainings in mindfulness. Meditation has been shown in numerous studies to reduce stress, and these are not just the feeling of stress, but also the actual physiology of stress. We have certain hormones and certain chemicals that go up in our body due to stress. And stress is a normal reaction. We all have stress when a lion is trying to eat us. And we know how to run very fast or, in rare cases, fight the lion. But usually we can't always do that with the stress of our daily lives now. So we need to be careful because this kind of stress builds up very gradually and sometimes almost unconsciously until it affects us. For instance, you know about heart disease risk factors, high cholesterol, hypertension, all those things. Stress actually is almost equal to hypertension as a risk factor, but it hardly ever gets on the list. Why? Because no drug company really makes anything that works on stress. There's a great technique called heart math, which I'll teach you just now. And then actually prayer has been studied a lot to show that it's a very effective stress management technique for people who believe in that. So heart math is a very strongly evidence-based. If you want to go and check the evidence, you can go to heartmath.org. And it's a very simple technique that we could try right now. What you do is, the first thing is you focus on the area of your heart, which is about 3 inches below your hand if you put it in the center of your chest. And then as you are focusing on your heart, then you start breathing in a very gentle, rhythmic way, and you imagine the breath going into your heart. And then you try and think about a very positive experience so that hopefully you can actually feel that positive experience. Like I remember when I first started Heart Math 3 years ago, I would think of when my little boy was 2 years old and would lie on my chest asleep with his arms and legs hanging down off my chest. And I remember that feeling of him lying on me. Interestingly, the research shows that the positive emotions of appreciation or gratitude have the strongest effect. And what this has done is you can actually go to HeartMath and buy a computer contraption that fits into your computer that measures with an earlobe sensor what's called heart rate variability, how different every heartbeat is. This is kind of cool too, because it comes back to that differences between you. Someone who has a very regular heartbeat, where the difference between each heartbeat is not very much, is actually under a lot of stress. Someone who has very different beats. Now, it's not irregular beats in terms of what I take when I'm your doctor, because we can't tell these differences. I'm talking about thousandths of a second difference between each beat. But the higher the heart rate variability you have, the better the balance between the stress hormones and the stress chemicals, adrenaline and cortisol, is. And guess what? People who have very high heart rate variability, especially if it's sustained over a period of time, have better cognitive function. So this is something we're doing research now at FSU to look at, would doing heart math help people with early Alzheimer's disease function at a higher level? So the 3 steps: heart focus, heart breathing, heart feeling, to feel the positive emotion. I do this for 5 minutes every day. If you were to do this on a regular basis, it's been shown in numerous different studies, 300 different studies, to lead to better outcomes. And finally, exercise. So exercise is the fountain of age. There is only one thing that is this is the only thing that is this good for you. It's amazing now with the number of studies in the last 15 to 20 years that have come out showing the benefits of exercise. It doesn't matter what kind of exercise you do. In fact, Dr. Schmidt said it right. The best kind of exercise to do is the one that you will do, because then it means you'll be doing it regularly. And the amount is simple: 15 minutes to 30 minutes most days of the week. Ideally 30 minutes most days of the week. Now, you don't have to be like Helen Zechmeister, who at 91 years old can lift 235 pounds deadlift. All these guys are amazed. She once competed in a men's 35 and older age group because there were no women to compete against, and she won. Now, here's some amazing statistics. So I can walk here, right, Lee, without losing the sound? Because this, I hope you can see this in the back, because this is amazing. Is obesity bad for you? Yes. Maybe. Yes, obesity compared to normal weight. So this yellow is unfit people, and the red is fit people. And it is true that fewer obese people are fit compared to normal weight people. But look at the actual death rate. These are the adjusted relative risk, taking out age, the exam year, smoking, and health status. People who are fit and obese have a lower death rate than normal weight and unfit. I'll say that again. If you are obese but fit, meaning you exercise 30 minutes, 5 days a week or more, you have a lower death rate than if you are normal weight and unfit. This is data from Steve Blair at University of South Carolina, who studied over 30,000 people over 30 years. It isn't that much in this particular study, but these are very large numbers. Is having high blood pressure bad for you? Sure. You can see that if you have, but I want to show in terms of fitness. So this one, the red is low fitness, the yellow is moderate fitness, high fitness. These are people who average 1 hour of exercise 7 days a week. If you have stage 2 high blood pressure, meaning your blood pressure is still out of control above 160 over 110, but you are highly fit, you have a lower death rate than if your blood pressure is completely controlled and you're unfit. Isn't this amazing? Fitness trumps hypertension. Fitness trumps obesity. In fact, fitness trumps everything. If you have diabetes, it shows the death rate of men and women now in red and yellow. that your death rate compared to people who don't have diabetes is higher. If you have high cholesterol, your death rate, especially for men, compared to people with normal cholesterol, is higher. If you have hypertension, that's a bad one for dying from heart disease. This is all heart disease deaths, by the way, which, by the way, is probably closely related to Alzheimer's, but not necessarily to Parkinson's. If you smoke, it's bad for you. You have a higher death rate. If you're obese, you have somewhat higher death rate. But if you aren't fit, that's the highest death rate of all. Now, billions and billions of dollars are spent on hypertension drugs, cholesterol drugs, and that's good. We should try and control those things. But we pay so little attention to exercise in our society. 30% of people over the age of 65 never exercise. So the single most important thing you could do for yourself is to start a regular exercise program. It has the strongest predictor in terms of outcomes.
What is exercise?
Exercise can be, the question was, what is exercise? And exercise really, as I mentioned before, is any regular physical activity that you will do on a regular basis.
But
Walking.
How much? How long?
So how much and how long? What you want to do if you haven't been exercising is start off at a low rate and a short time to just make sure that everything goes okay. It's kind of a myth that you have to go to a doctor and have a whole exam before you start an exercise program. However, if you've had problems with exercise in the past, or if you have active heart disease that's not controlled, then you should see a doctor before you start. However, I have to say, what's interesting is, you know what one of the most effective interventions there is for people who have had a heart attack or especially heart failure? Exercise. Now they do it in a controlled fashion, what's called a cardiac rehabilitation program, and Medicare pays for that. But otherwise, if you don't have those problems, either a pre-existing problem with exercise or an active, uncontrolled heart problem, then the easiest exercise of all to start is probably walking. And just gentle walking at a speed that is comfortable where you can talk to a friend. It's always good to exercise with a friend. Number one, because unless it's your husband, it'd be nice to have a different friend. One, so you don't get into arguments, but two, so that they're waiting for you. It's hard sometimes to get up the gumption to go exercise, but if you know they're waiting for you and you're going to disappoint them, you've got a little more motivation to do it. But I always recommend walking. If you have knee problems or hip problems, then swimming is a great exercise, particularly for people with arthritis. And I don't mean swimming laps, but just doing pool exercises, aerobics in the water. Bicycling is a very good exercise, stationary bicycling, and recumbent bicycles are probably better for anybody that has balance problems. So people with Parkinson's also often benefit from a recumbent cycle where you're sitting down on a chair and the pedals are out in front.
So you wouldn't say that doing housework, working in the yard, going up and down the steps 6 times a day, that you can't count that as exercise. You have to do something out somewhere.
Okay, that's a very good question. No, actually the research shows that gardening, housework, going up and down stairs, any of those things are contributing to the total number of minutes that you have during the day. The problem with like stairs or cleaning house is often you may not do that for that long. So in fact, has been shown that 10 minutes 3 times a day is as effective as 30 minutes in one time. How about other questions about that? And there are groups, many different kinds of groups that you can join too, which is always helpful. So what do we know about exercise in Parkinson's? It does appear that exercise, come back to your question earlier, exercise is the one intervention we know that may prevent the development of Parkinson's. It's not clear yet. Part of that research is very hard to do because most people develop Parkinson's in late life, and so you have to wait a long time to see what happens. And there's an old joke, we call that cohort effects. You take a person you're looking at a group of people who are similar and you watch them over a long time and see what happens. But this is a cohort group. They may not be just like you. And the problem with cohorts is you have to be careful that the group is like you. And the old joke in geriatrics is if you believe cohort studies, then you have to believe everybody in Miami is born Hispanic and dies Jewish. Cohort of births and deaths. But I think it's certainly a good reason to do it, especially if it's in your family. We do know that it does slow progression, so that if you look at people's functional status on standardized measures, and the exercising group has a slower progression of Parkinson's than the non-exercising group. We know in fact, there's a thing called Cochrane collaboration. These are experts around the world who evaluate all the evidence that's been done and then release a report saying, here's what we think is the best evidence that we know about. And the Cochrane collaboration has said that regular exercise enhances walking speed and distance and enhances balance and increases quality of life. So this is a very important intervention to use in Parkinson's. And the last thing is controlling your destiny. So I used to call this advanced care planning, but it sounds very clinical. And a writer, you all know Ellen Goodman, the writer? So she's a real famous writer who said, back in the 70s, women said, how come birth has become a medical experience? Birth is a normal experience women have been doing for the beginning of time. And so the natural birth movement was started. What Ellen said was, how come death is a medical experience? This shouldn't be a medical experience. This is a normal part of life. We should be talking about it over the kitchen table, not over the ICU bed. And so she started this project called the Conversations Project. And if you just Google the Conversations Project, you can go to that site and get involved. You can write your story, you can start talking, and there's a toolkit they can send you that will help you start the conversation with your family so that people can understand what it's like to be facing the last decades of life. So this is the important thing, is to start off with a thinking about your own personal goals and values. There's a great mechanism for doing this called Go Wish cards. It's like Go Fish. So the website is down there, gowish.org. And what these are is a set of, you can buy the cards, it costs $8 a pack, or you can do it online, right on the website, gowish.org. They're a set of 36 playing cards, and they have very simple statements about the things that people think are important in terms of their goals at the end of life. To be with my family, to not die in a hospital, to be at peace with God, to resolve my family differences, and all kinds of other things. And what you do is, you take the 36 cards, and you lay them up, face up on your kitchen table, and then you go through them and sort them out. What's very important to me, what's not important to me, what's in the middle pile. And then you take the very important pile and you pick out your top 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Order it. And then, if you're having this discussion with your family, you say, this is why this one's important to me. And that starts to give them, and especially your children, a very clear idea of what you think is important about your goals and values in life. It's not just about death. It's about choices around medications. It's about choices around living place. It's about choices about how aggressive to go on interventions. But the important thing is that they understand these are your goals and values. We're doing some research on this now at FSU, and we're looking at how does this work with people with early Alzheimer's, and can they think through these? And it looks like there's no problem. And I was doing that with one patient, and he picked out, surprising to me, that his number one very important thing was to have a doctor who knows me. And the reason was because it turned out he had had years of serious lung problems going back and forth with doctors. And he always had to tell the same story over and over again. And he was very worried now, as he got Alzheimer's, that he wouldn't be able to tell his story. and that he wanted to make sure the doctor knew him and what his values and goals were as he starts to lose more and more of his mental abilities. The second part, though, is don't do it alone. Make sure your loved ones know those goals and values. I recommend people write their top 10 and they put that in their file of life. Do you all know what a file of life is? An envelope that you put on your refrigerator that has the other things I'll talk about as well, right there, so people know those values. The reason why this is important is because we as doctors can't figure out exactly what you mean. We can't take the time or even do it because we don't know everything that is possible that could happen to you. I once had a nurse who was seeing me for private care. She was an ICU nurse, and she came in with an advance directive, and she had an attachment of 20 pages of things that she didn't want or wanted. And she was an ICU nurse. She knew everything about intensive care at the end of life. And I said, can you give me a little leeway here? Because you might get into a situation that doesn't exactly fit what's on your list, and I don't exactly know then what to do. How about if we just talk about what your goals and values are? And yeah, the big ticket issues like, do you want to be resuscitated? Do you want to be tube fed? These kinds of things we can talk about, but not every single medical condition that's possible. But I do think you should have an advance directive, and we have a very good one that was created by Jim Toohey here in Tallahassee called 5 Wishes. And 5 Wishes is a document where you can put on there the kinds of treatments you want or don't want in certain circumstances, as well as some listing of values. Something to think about is there a fate worse than death? So I'll be very honest and just tell you mine. Now, I do all this research about Alzheimer's. I take care of a lot of Alzheimer's patients. And through that time period, what I have come to the decision of is I don't want to live in what's called stage 7 Alzheimer's. That's where you can't recognize your family, you can't eat, you can't move on your own, you're completely bedridden, you can't talk. Now, how do you get to stage 7? Here's the hard part. Really good medical care. Treating everything that happens so that you can live longer to get more demented. I had a patient one time, we had gone through all kinds of discussions about what she wanted or not, and actually her son, because she was too demented to have the discussion. And one night she was in assisted living and her heart rate was 240, and she was now comatose, not comatose, but what we call obtunded, meaning she's not responsive. So they called 911, unfortunately against the orders that we had, got her to the ER. The ER doctor gave her some medicine. Her heart rate came back to normal, and she woke up and she was back to her normal self, which was good. And the son, who was a commercial airline pilot, very bright guy, goes, she's had those problems with slow heart rate, and now she's got this fast heart rate. Do you think she needs a pacemaker? And I said, well, she has a problem that often a pacemaker is used for, called sick sinus syndrome. If we put that in her and gave her medicines to control the fast heart rates, then what we could be assured of having is that she will live longer so that she'll get more demented. Do you think that's what she wants? And he said, oh no. Every day she says to me, why doesn't God take me? I'm ready to go. So I said, well, it sounds like the right treatment is we have to stop taking her pulse. So you need to decide what is a fate worse than death for you. It might be very different. I've known patients who want to go as long as possible. I've known patients who say, I want to go until my granddaughter graduates from Yale. And I've had people saying, this isn't a life worth living right now. I want to stop these medications. And frankly, this is going to probably get some pushback from your doctors. It's really hard for a lot of doctors to stop diabetes treatment, to stop hypertension treatment. But if you want to have a sooner death than later in that circumstance, that's the way to do it. So that's a choice that you have. You can control your destiny. The most important thing in all this discussion is to name a surrogate. Name someone who knows you, who cares about you, and who doesn't love you so much they couldn't live without you. Because if they're going to have to make decisions about whether to do something or not, They have to be strong enough to be able to make that decision. But they must know your goals and values to make those decisions. And start telling people, let's start the conversation so this isn't such a big taboo issue in our society. In fact, I'll challenge the National Parkinson's Foundation. Put it in that top 10 list of things. Everybody with Parkinson's is going to die. Not necessarily of Parkinson's, but see, here's a simple fact. Since 50,000 BCE until 1895, every single human being has died. The longest anybody's ever lived is 120 years. But I can guarantee, unless something miraculous happens, everybody born since 1895 to now is going to die. It's just a normal part of life. So why don't we just plan for it instead of running away from it?